So thank you guys for coming this morning. My name is Lisa Hong. I'm one of the second-year internal medicine pharmacy residents. And I'll be talking briefly about anti-arrhythmics and kind of some side effects and things that I think are important for nursing to know. So on the left side of the handout, you'll see that I put the von Williams classification of the anti-arrhythmics, and there's classes 1, 2, 3, and 4. And 1's broken down into 1A, 1B, and 1C. I did not include classes 2 and 4. Those are beta blockers and calcium channel blockers. I thought I'd spend time focusing more on the anti-arrhythmics that we see less commonly, or more commonly, but less commonly than beta blockers and calcium channel blockers. And then of the class 1 agents, I have not included 1B. That includes lidocaine and nextellitine, and we really don't use those often. We'll sometimes see lidocaine in code situations, but it's pretty rare that we see that used. So again, I did not include those today. So we'll start with 1A, and these agents include disopyramide, procainamide, let me grab a handout, and quinidine. Disopyramide has, all of these are on formulation here at the U, and disopyramide has both immediate release and extended release formulations. And barcode scanning should prevent errors for administering one for the other, but I think it's important to recognize because that would change the dosing frequency, as you can see, from every 6 hours to every 12 hours for that medication. And then for procainamide, we have the IV formulation, and really the biggest point here is that there's a maximum infusion rate. So the max infusion rate is 50 milligrams per minute for procainamide, and there are a couple different ways that this agent can be administered. So it can be administered as 100 milligrams every 5 minutes until an arrhythmia is suppressed, and so if that were to be done, you'd want to push it over 2 minutes. Or it can be a continuous infusion at 20 mg per minute for 25 minutes, and both of those strategies would really give a total dose of 500 milligrams. So if it's a continuous infusion, the rate isn't really something we'd have to worry about as much, but if it's the larger dose, then we need to push it a little bit slower, so over 2 minutes. For quinidine, important things about this is that there are different salt formulations available. So there's quinidine gluconate and quinidine sulfate, and these are not equivalent. And so if there were to be a switch between the two, there is a slight dose reduction that would be needed to go from gluconate to the sulfate form. And so I think that's important to just recognize as well. Again, barcode scanning should prevent that from being an issue, but I think it's good to recognize. And it also comes in an IV formulation. Typically it's infused at 0.25 milligrams per kilogram per minute. If that's titrated up, the maximum is 0.5 mg per kg per minute. And interestingly, this medication does adsorb to PVC tubing, but the manufacturer doesn't really have specific recommendations on what types of tubing to use, which I thought was interesting because we have non-PVC, but they just say to reduce the length of the tubing as much as possible. So something to keep in mind. And I tried typing that order into Epic to see if it linked to a different type of material, and it did not. And so just something to recognize. And if it's something that's not working in a patient, it might be due to the fact that it's absorbing more to the tubing and not getting into the patient. So I thought that was an interesting fact about that. So then moving into the class 1C agents, these include flecainide and propafenone. So these actually, all of these agents work by blocking sodium channels, and the 1C agents tend to do this more markedly than the 1A group. So they're used more commonly to help to suppress arrhythmias for that reason. And both of these are oral formulations. The propafenone has immediate and extended release, and they can be used in the outpatient setting as pill-in-the-pocket medications. I'm not sure if you guys have heard of that before, but basically when patients have an arrhythmia and they have symptoms, they can just kind of take one pill. The problem with that is that not all patients are symptomatic when they go into, say, atrial fibrillation, and so that can be an issue. But that is an indicated dosing method for both of these agents. And then all of these class 1 agents can cause heart failure, heart block, hypotension, and bradycardia. But some side effects that I wanted to point out that are different. So with disopyramide, we see anticholinergic side effects. And so this can be problematic in patients with glaucoma or BPH because it's going to cause the urinary retention, it's going to cause dryness, dry eyes, dry mouth, all of those sorts of things. And so that's something that's unique to a disopyramide. With procainamide, it actually can cause lupus in up to 30% of patients. So patients who are on this for longer periods of time can develop positive ANA levels, and so if you see those ordered for patients who are on this, that's why, is because I'm monitoring for that. This
Which
agent,
one's that? Sorry.
that was procainamide in the 1A group.
Oh.
And this medication can also cause blood dyscrasia, so neutropenia, low white count, thrombocytopenia, low platelets. And so checking CBCs weekly is something that's recommended, and so you might see those orders on patients who are on that as well. And then something that I want to point out with quinidine is hepatotoxicity. So monitoring LFTs is important in this agent because of that risk in this medication. And then propranolol, interestingly, is structured similarly to propranolol, and I think it'll be easy for me to remember as a pharmacist. I like to use little tricks. So propranolol and propranolol, they kind of start the same, and they are structured similarly, and so propranolol actually has some of that beta blocker activity. So because of that, and because propranolol is a non-selective beta blocker, it can cause bronchospasms and would not be ideal in somebody who has, let's say, COPD or asthma for that reason. Are there any questions about the class 1 agents?
With the quinidine,
Yeah.
you know, with insulin, it leaches into the tube, and so we just have to, you know, what's the word I'm looking for? We prep the tube with the insulin. We wait for a certain period of time, and then we dump that initial insulin. I mean, is that basically something we might do with the quinidine as well?
When you say dump, is that like going into the patient?
No.
Okay.
So you let it sit in the tube for a while until I don't know, a certain amount of time.
Okay.
And then you just let
You
that
waste
first
that
amount
amount that was-
flush.
But it doesn't flush
On the
into the
tubing.
patient. It
No,
just
so then we would let it
outside.
sit, and then we would
Okay.
flush all the way through that
Okay.
amount of tubing.
Yeah, I didn't see anything from the manufacturer recommending that to be done with quinidine. Their only recommendation was to shorten the tubing length. And so I would say I don't have any data to support that that's something you would do.
Okay.
But I don't see this agent used too frequently. I'm not sure if that's something that's been attempted for
Okay.
this before, but that's a good question. Hi. You want to have a hand So then we get into the class 3 agents, and these are ones that I really want to focus more on because these are ones we see most commonly. And these work by blocking potassium channels, although some of them will have additional mechanisms of action that I'll talk about. So we'll just start with amiodarone. And so this it's available in both IV and oral formulations. And if it's given IV, it's preferred to give via a central line to reduce the risk of extravasation. And then additionally with amiodarone, it's important to use an inline filter. And the filter that's needed to be used is a 0.22 micron filter. Now, when entering the order in Epic, there is not a specific area that notifies you of the filter, and so when that becomes an alert is actually when it's set up in the Alaris pump, and then the notification to grab a filter comes up when setting up the IV drug in the Alaris pump. So it is not tubed up with the filter, and the filter is in the Omnicells or the distro machines, and so That's something that's important to know because you will have to grab those separately. They won't be sent up together. And again, it's the 0.22 micron filter that's recommended.